Good morning and welcome to session 4 of the Immunisation Coalition's annual scientific meeting. This session is on other considerations and looks at a number of aspects around COVID-19. The first presentation is by Dr. Stanley Perlman from the University of Iowa. Stanley's current research efforts are focused on coronavirus pathogenesis, including virus-induced demyelination and SARS, MERS and COVID-19. His laboratory provided the first rodent model useful for studying MERS. Among other topics, his research is now focusing on the loss of sense of smell and taste observed in patients with COVID-19. Welcome, Dr. Perlman.
Thank you, and I want to thank the organizers for inviting me to give a talk. The only thing I regret is giving it by internet and not being there in person. So what I'm going to talk about today is the natural history of coronaviruses and what they do, and I'll be referring to all of the coronaviruses except SARS-CoV-2, which I know is covered in other parts of the session. So coronaviruses are these viruses that are named because they have these projections coming from the surface of the virus, and I know this has been covered already, so I will go quickly over this. And they're within the nidovirus order. They're called nidoviruses because the RNA for these viruses are made as nested sets of sequences, and it took a long time to figure this out, but now we pretty much understand how this is done. The points, this is a schematic of the virus, and the points that are important is the spike protein is the target of the antibody response and is the one that we talk about all the time when we talk about COVID-19 vaccines. There are also these other proteins that are involved in the structure of the virus. These viruses are quite large. They're 31 kb. The only other viruses that are larger, that are RNA viruses, are actually in the same set of nidoviruses. And the largest one is in an insect nidovirus. So the smallest species has the largest RNA virus. We don't understand why. Even before we had knowledge about human pathogenic coronaviruses, we knew that these viruses cause serious diseases in companion animals and domestic animals. So cows have developed chipping fever, and swine develop basically diarrhea. A virus called transmissible gastroenteritis virus, and several others. And in the laboratory, we and others were particularly interested in mouse hepatitis virus, which causes a disease that's very similar to the human disease, multiple sclerosis. There are 6 known human coronaviruses. 2 of them, SARS-CoV and MERS-CoV, were before SARS-CoV-2. And OC43, 229E, NL63, and HKU1 cause the common cold. The coronavirus outline timeline is shown here. OC43 and 229E were found in the 1960s, and they caused the common cold, and occasionally they were reported to infect the lower respiratory tract, and that may be an important point, which I'll point out in a few minutes. After that, in the 1940s, and then developed more in the 1980s, this virus, mouse hepatitis virus, which causes brain disease, was identified. And then people started developing vaccines for these animal coronaviruses. And then over these years here, the basic coronavirus biology was identified. SARS-CoV was identified in 2003, and then 2008 or 9 it was realized that these were bat coronaviruses. We suspected this before, but these are bat coronaviruses that entered human populations. HKU1 and NL63 were found after SARS-CoV, and then MERS was identified in 2012, and then SARS-CoV-2 more recently. So these are some of the places that we think the coronaviruses arrived. We think these are, for the most part, bat coronaviruses. 229E and NL63 diverged about 1,000 years ago. 229E entered human populations maybe 300 years ago. People think NL63 may be a few hundred years longer than that. OC43 entered human populations 120 years ago. And the thing that's interesting about OC43 is that it may have entered human populations at the same time as a disease called Russian flu was noticed to be common. And the speculation, not proven at all, that OC43 was actually causing this Russian flu, which was a slightly more severe form of flu. This is, of course, hopeful for us now, because if OC43 evolved from being a more serious disease to the common cold, that, of course, would bode well for SARS-CoV-2, hopefully becoming a common cold coronavirus. No evidence that it's doing it, but that's what we hope. So there's other spillovers that I think are worth noting. And there's a spillover of canine coronavirus that was noted just last year in Malaysia. 8 children developed pneumonia, and a novel coronavirus was isolated from these children. What was interesting about this virus is that it had a lot of resemblance to canine coronavirus, 2 different strains, 1 and 2, but also apart from the feline coronavirus. So this virus was a mixture or a recombinant of feline and canine coronaviruses. We know this is possible because feline, canine, and pig coronaviruses, the TGEV, all have very similar structures, and the virus crosses species. So this is very similar to what we know about with SARS-CoV-2. There's a recombinant virus. We don't know where it came from, and it was able to infect humans. Luckily, this virus has not continued to infect people, but it's certainly something worth looking at because none of us have immunity to the virus, except, of course, the 8 children who were infected. And similarly, in Haiti, there were 3 introductions of a porcine Delta coronavirus. Usually, these do not infect people, so this is the first time this was reported. And this was found in children with fevers. They did not have enteritis or pneumonia. So this is another example of coronaviruses crossing species. This was a bat coronavirus that jumped to infect pigs. It causes a disease called swine acute diarrhea syndrome, or SADS. And the people who did this, which was Zheng Yuxi in Wuhan, found that this virus was 99 or 98.5% related or identical to a bat coronavirus, HKU2. So 98.5 is higher than we have for any bat coronavirus with SARS-CoV-2, but still is a few hundred nucleotides different. So it's not a direct leap yet, but it's much closer. And this all occurs because there's a high frequency of coronavirus recombination. RNA viruses readily combine, particularly coronaviruses, and coronaviruses have a lower frequency of mutations than other RNA viruses. And this may be facilitated by the unique method of leader priming that leads to the nested sequences of RNA that I'm not going to cover today, but this could contribute to a high rate of recombination. And recombination makes it easier for viruses to cross species. And in camels, there's evidence for recombination between circulating strains of MERS-CoV. And I think I show that in the next slide. So this is several strains of camel coronaviruses that were isolated and are very similar to MERS, if not identical. And what they show is that there's clear recombination at different sites within the genome, and that these different recombination events don't occur in people, they occur in camels, and we don't know if it's the camels being seeded by different lineages of MERS-CoV, or if there's another animal that's actually circulating and providing the source for the camel coronavirus. So the reason that coronaviruses have lower mutation rates than other RNA viruses is because they're so large. So these viruses are, as I mentioned, are about 30,000 nucleotides, and if one's that large and has the usual rate of error that RNA viruses have, then one can see from this data that each virus would have about 3 mutations, so it would be quickly extinguished. So instead, what the coronaviruses do is they encode a protein called exonuclease, XON, and this provides some proofreading activity. And it reduces the level of error to much better than is seen with other RNA viruses, but there's still more errors than are seen during RNA replication, than DNA replication of the host or DNA viruses. So this gives some proofreading, but it's not perfect, so this allows the virus to mutate and adapt to new environments. So I want to now discuss a little bit about some of the principles of immune protection that we know from coronaviruses from these prior infections before SARS-CoV-2. So we know that in experimentally infected animals, both virus-specific antibody and T cells in sufficient quantities can mediate virus clearance. And in fact, both are required in the natural infection for clearance. So in one set of experiments, which my lab did, this was just with mice infected with a murine coronavirus. What we found is that if there was no, we didn't do this another group did. The first point here, in the absence of antibody, virus may recrudesce. So virus is cleared, the animals get all what appear to be clinically normal, and then a few weeks later virus recrudesces and the animals do poorly. On the other hand, if a mouse doesn't have T cells, and these mice don't have if they don't have T cells or antibody, so these are these RAG1 knockout mice. If they don't have either one, virus is never cleared. So they would, in theory, die from the infection. But in fact, if you protect them with a tiny little bit of antibody at the time of infection, then the animals actually survive for quite a while, for at least 3 to 4 months. And if one looks in these animals, there's high titers of virus present throughout the animal, but the animal doesn't really care. And in fact, we know if we take these animals and deliver either antibody or T cells, they actually get sick and develop brain disease. So there's virus in the brain, there's virus everywhere in the animal, but without this immune response, the mice do actually very well. We don't know if mutations occur in these basically bags of virus, these animals that are loaded with virus, but what this certainly does is support the notion of immunopathological disease in coronavirus infections. So the vaccines have been developed, as I mentioned earlier, for these domestic and companion animal infections. And one of the things that's really common is protection was imperfect. So one of the first ones that was examined was feline infectious peritonitis virus. I didn't mention this one earlier, but this virus normally causes just diarrhea in cats, and at that point it's called feline coronavirus. But some cats become persistently infected. And during the course of persistence, the virus mutates, and as the virus mutates, it can now infect macrophages. So this is the only situation I know of in coronaviruses where one can clearly show that antibodies will enhance infection, because this is similar to the other well-known entity of antibody-enhanced infection, which is in dengue fever, where antibody enhances infection of macrophages. For most other of these infections, so for example for SARS or MERS or SARS-CoV-2, there's no infection of macrophages. The infection is abortive, which means you don't get productive virus, so you can't enhance it with antibody. It may still have an effect, but it won't be enhancing replication. The result of this is if one immunizes a cat with a immunogen that delivers antibody to the surface glycoprotein, cats actually die more quickly because they now have antibody-enhanced infection of the macrophages, which leads to both more virus replication and higher levels of cytokines and chemokines. Another entity that people tried to develop vaccines against was transmissible gastroenteritis virus, which causes fatal diarrhea in newborn pigs, but vaccination had variable success. And this was partly because the vaccine didn't deliver protection in the mucosa of the baby pigs. It gave good systemic protection, but not to the mucosa, so the baby pigs still developed diarrhea and died from that. However, it turns out this virus is really not a problem anymore because nature provided a protective vaccine. This virus is called porcine respiratory virus, and what this virus is just a version of TGEV, but it's lost the ability to infect the gastrointestinal tract. But it still infects the respiratory tract. And what happens is pigs get repeatedly infected with porcine respiratory virus, because like other respiratory viruses, it doesn't induce good immunity, but if a pig is infected multiple times, it does. And because of this, the maternal pigs, the mother pigs, are able to deliver antibody to babies, and they're now protected against TGEV. So in fact, TGEV is no longer a problem. However, this is not the end of the story for pigs, because as I showed in an earlier slide, pigs still develop diarrhea from either porcine delta coronavirus or PEDV, porcine epidemic diarrhea virus. So it shows that, and maybe SADS, the other virus that I talked about, will infect pigs too, but that seems to be limited to parts of China right now. So the other thing that these results show is that live attenuated vaccines result in the most effective protection. We don't use live attenuated vaccines easily because we always worry that the viruses will no longer be attenuated with time. And this is seen in the next illustration that I'm going to present here. So another virus that was well understood early on was infectious bronchitis virus. This was the first coronavirus to be identified, and it causes bronchitis in very young chickens with a high mortality. In this case, the death results from obstruction of airways. So once again, it's the excessive host response to the virus that's lethal. In this case, what is happening is excessive secretions, much like what happens when people develop a cold. So the vaccines were developed against IBV, and it turns out that these vaccines had problems because avian coronaviruses are always evolving in nature. It sounds similar to SARS-CoV-2. Live attenuated vaccines were developed and are used in chickens, and what happens is there's frequent vaccine modification, and this resulted in recombination within the field. So most of the viruses circulating were in fact recombinant vaccine strains. Now I think there's new ways to immunize chickens now, so this is less of a problem. So moving on to human coronaviruses, the human coronaviruses that I mentioned earlier cause about 15 to 30% of common colds. There's no durable immunity. There's frequent cycles of reinfection, and as we all know, the most common clinical manifestation are these upper respiratory tract infections. Viruses, especially when the pandemic was beginning, there was a little bit of information that guided us in thinking about how immune protection might work. So we knew that the common cold is the immunity that we develop is only transient because people become reinfected. We know that waning immunity occurs, waning antibody titers are detected, just like what we're seeing with SARS-CoV-2. And one study I think that showed this really nicely was done in 1990. And what this study showed is 15 volunteers were recruited, and they were inoculated with one of these common cold coronaviruses, 229E, and 10 of these individuals who had lower antibody titers than the rest became infected, and 8 of these people developed colds. So then these people were sent home, and then a year later they were brought back to the testing site and re-challenged with the same strain of 229E. 9 became reinfected, but none developed a cold. And it was noted that of the 9, 6 of them shed the virus, but of shorter duration than normally seen. So titers of virus were not measured, so we don't know if there was still shedding, but much, much lower than what was seen if someone was naive to the virus. We suspect so, but that was not shown in the study. And another study tracked common cold coronaviruses over 35 years. This was done by serology and showed that reinfections occurred every 6 to 105 months after the initial infection, and reinfection was common after 12 months. So again, showing that protection is transient. I think what we're learning to some extent with SARS-CoV-2. So then to go over the human pathogenic viruses and see what we've learned from these infections. We know SARS was present in 2002 to 2004. Unlike SARS-CoV-2, as I think everyone knows, this was a lower respiratory tract infection, and what this meant was that people who were infected became contagious only after they developed pneumonia. So it was relatively easy to identify these people and quarantine them, and that's why it was possible to end this epidemic in 2004. During the epidemic, there were about 8,500 cases, and of these about 10% mortality. So the one thing to put this into context is that 8,400 cases was about the number of new HIV cases in 2003 in about 12 to 16 hours. So in terms of health risks to humans and humankind in general, this was nothing compared to HIV, but it was certainly a big deal because one could get on an airplane in theory and be next to someone who's coughing and then develop SARS. So the fear factor became important. People realized that these viruses could cause pandemics and epidemics, and there was a huge economic losses. Now at the end of SARS, one might say, what was done? Well, there were some vaccines that were started, but they were terminated because the virus went away and people stopped thinking about SARS. There were some things that were done. The research continued. which was fortunate because all of that information became useful as COVID-19 appeared. So SARS appeared in Guangdong province in China in 2002. It spread in wet markets, and this was different than SARS-CoV-2 because it was clear that the virus was spread by these intermediate animals that I'll show in the next slides. But it took a while to prove that bats were the original source for the virus. With SARS-CoV-2, we have a better feeling for bats being the original source, but we don't really have a good idea on how the virus crossed species to infect humans. And we know that these viruses cross species many times to infect people. So we know they're originally a bat virus. They infect these civet cats and raccoon dogs, and then infected humans. Humans spread, but contact was close contact was required for spread, and people had to be sick for spread to occur. And then this was mostly a disease in China, and it spread elsewhere around the world, but as I said, ended in 2004. So the virus was likely transmitted to animal handlers several times because there was a 35% seropositivity, but the epidemic occurred because there was a single set of transmission events involving a physician in Guangzhou who traveled to Hong Kong. He took care of an animal handler. He became ill. Instead of going home to bed, he went to Hotel M in Hong Kong to his nephew's wedding, became very ill, and infected everyone else on the same floor, the 9th floor of the hotel, which is here. This is a hotel, Metro Park Hotel Kowloon, and there's me taking a picture of it. My friend said if I visited Hong Kong, I had to stay at the hotel. Thought if I stayed, I should look for the key room in question, but room 911 is missing. There's only room 910, and then it goes to room 914. So the hotel, for various reasons, decided to eliminate 911, the room that was implicated in this physician's illness. So then thinking about MERS, this was Middle East Respiratory Syndrome, was first documented in April of 2012, and the number of cases of this is actually much lower than even of SARS in 8 months. It's been 2,500, even than SARS in 2 years. There's been a total of 2,580 cases as of the last year. This says June 2021, but there were only 14 cases between January 1st and November 1st. This has a very high mortality, 34%, but I don't know that this is correct because there's many people who seem to have asymptomatic or subclinical infection, so we don't expect them to we expect the death rate would be lower if we could actually count all these people, but so far we've not been able to prove that one way or the other. The median age is 49, and much like with SARS-CoV-2, infection ranges from asymptomatic to lethal. Just like SARS, this is a disease of the lower respiratory tract, and the people who actually have asymptomatic infection seem to have very either mild infection of the upper respiratory tract, but it's really like SARS. These people are only contagious after they develop pneumonia. And in these people, the antibody response is often transitory, so it makes epidemiology studies difficult. And we don't know if there's an increased likelihood of reinfection because there's so few cases out there that it would be hard to identify reinfection. And at this point, there's very limited human-to-human transmission. When this was really in the news in 2012 and 13 and 14, it was because transmission was occurring in the hospital. People were not being careful in using appropriate infection control procedures. And in addition, the way this virus and SARS spread was during procedures like intubation and suctioning when the virus was aerosolized from the lungs. And at this point, about 50% of cases actually are primary, so not from interhuman contact. And just like with SARS-CoV-2 and probably with SARS, the people who get worse disease have comorbidities, including diabetes, chronic lung disease, renal failure, or an immunocompromised state. So this one, again, is a bat virus, and for this one, we don't really know the bat virus so well. It showed this species, which is found in South Africa, has a virus that's similar to MERS has been identified, but we don't know that this is really the original source. But we do know that somewhere along the line, camels became infected, And then the camels infect each other. They're very close to each other. And what it causes in camels is rhinitis. So camels have basically a common cold. And then humans get infected from camels, particularly in Saudi Arabia. Camels are pets, and they may infect humans directly. And then there's a limited human-to-human spread, except in hospital, occasionally in household settings. And so this is a disease in the Arabian Peninsula. There was one subsequent outbreak that's interesting from a few points of view. A traveler from Saudi Arabia went to Korea. The disease wasn't recognized. There were 186 cases before the outbreak was confined. And what was interesting was that the virus, it wasn't so interesting that 20% of people died, but the virus evolved a little bit during the outbreak, and it actually became less virulent in people. And there was only the single introduction, so it's really different than either MERS or SARS, MERS in Saudi Arabia, or SARS-CoV-2 with this multiple introduction into human populations. Since this is an Arabian Peninsula virus, it's just not going to be found in many places. So one thing that's curious about this disease is that it's found in camels throughout Africa, and these red circles don't show a minimal amount of infection. Some of these places, 70-80% of camels are infected, yet there's no human MERS in Africa. And this is an area of curiosity. We don't know if it's the virus, social conditions, genetics of the people. This is still being investigated at a low level, or testing, because testing isn't widespread. And in fact, even in Saudi Arabia, SARS-CoV-2 or MERS-CoV, antibodies were detected as early as 1992, but crossover into humans didn't occur till here, to 2012. So why did MERS cross over only in 2012, and why only in the Arabian Peninsula? So these are research questions that are of interest. And so we know something about immune responses in these people. Antibody responses in MERS patients are critical for protection against re-challenge. We don't know about mucosal antibodies, but it's likely important. We know, as a side note, that SARS patients' antibody responses were thought to be short-lived, but in fact studies now redone during SARS-CoV-2 show that neutralizing antibody can be detected in patients even now. And we did one study with Chinese collaborators showing that the antibodies could be detected at least 15 years after SARS. But they wane quickly. These patients had mild pneumonia. They have a good antibody response here. This is an ELISA assay, but by 18 months it could no longer be detected. And we found that T-cell responses could be detected, and I'll just go quickly through this. People who were in the ICU developed a good CD4 T-cell response and a good antibody response, and the longer you're in the ICU, the better the response. CD8 T-cells seem to not correlate with this at all. In fact, if anything, the opposite. So the results seem to suggest that the CD8 T-cell response corresponded with less severe disease, while CD4 and antibody responses correlated with more severe disease. And we know, just like with SARS-CoV-2, the more robust and durable the responses are, the more severe the illness, the more robust and durable the responses are. So, and this is just one point since I'm running out of time here. I just want to make this point. One of the things that was done in MERS is people started developing vaccines, and this vaccine here, this is the forerunner of the AstraZeneca vaccine that's in use now. And what was learned from this, there's several points, but one was that with a single dose, neutralizing antibody titers were not developed in a large number of people, 4 out of 9 at 28 days. So this was one of the reasons that now the AstraZeneca University of Oxford chimp adeno vaccine is given in 2 doses, because we knew from this prior study that one wasn't very useful. People developed T-cell responses, so those were more longer lasting. And so just to finish up here, so I just want to cover what have we learned about SARS-CoV-2 that's not new, the same as other coronaviruses. We learned that coronaviruses cross species. They cause disease of variable severity, and control requires all parts of the immune system, innate, adaptive, and memory responses. And it can be controlled by robust neutralizing titers. Of course, if you have too many variants that change, that won't be true. And many of the manifestations are caused by host immune responses, and all these human pathogenic coronaviruses are most severe in people with obesity, diabetes, heart disease, so with comorbidities. And what have we learned that's new? Well, we know that SARS-CoV-2, even though it's a respiratory tract pathogen, it doesn't infect, but affects several organs like the brain, kidney, heart, and pancreas. We don't know why, and we don't know how this is working. And some of these things can be identified or addressed using animal models, which I won't talk about today. But we've learned even recently that these viruses can cross species even again. 80% of deer in one study in my state in Iowa showed evidence of viral RNA in lymph nodes. 36% of deer in Ohio were positive. So this is a very promiscuous virus, and it crosses species. Bovine coronavirus cross species to infect antelope and other ruminants, and it's very similar to the human disease OC43. So the goal of these viruses, we've learned, is really to be transmissible, and virus mutates to achieve this goal, and this is what its main point is of all these variants of SARS-CoV-2, to increase transmission. We know that transmission involves virus intrinsic factors such as binding to the receptor, ACE2, but there's others that are not understood. And we know that immune evasion may not have been important so far in these variants developing, but they will be. So, for example, the beta variant is the most immunoevasive that we have, except maybe for Omicron, and this was detected at times when numbers of individual who were immune was very low. This virus never became dominant. And Omicron, of course, is immune evasive. But we found that many of the mutations in Omicron were also found in mouse-adapted virus in the absence of immune function or immune selection. So we know that vaccines are protective. We know that because of the pandemic, for the first time we have oral therapies that are useful against a variety of coronaviruses. We know that anti-spike antibodies are useful, but they are prone to immune escape. And we know that antibodies responses wane, and the waning of vaccine efficacy are more consistent with mucosal rather than systemic infection, which is the same as all these other coronaviruses. And as the pandemic recedes, probably the most important thing we will have to think about is diagnosing and treating long-term effects of COVID-19, because this may have long-term health issues, long-term health, long-term effects on the healthcare system, and maybe similar to what we saw with the 1918 flu when people developed encephalitic or lethargica. And with that, I would like to stop. This is on a more cheery note of what coronaviruses can look like. This is a vero cell that's infected with the viruses, and while this picture is pretty, of course, the virus is lethal. So with that, I will stop, and thank you.
Thanks, Stanley, for a fantastic talk. Our next talk is a different aspect of COVID, and it's looking at the psychiatric aspects of the pandemic. The talk will be presented by a colleague, Associate Professor Alex Holmes. Alex works in the long COVID clinic each Tuesday morning at Royal Melbourne Hospital and has been doing that for the last 2 years. Alex's main role at Royal Melbourne is Head of Liaison Psychiatry. He also has a clinical attachment with the Homeless Outreach Psychiatric Service, which covers the Melbourne CBD. Welcome, Alex.
Thank you, Lou, and thank you for the invitation from the Immunisation Coalition. I'm a consultation liaison psychiatrist at Royal Melbourne Hospital and been working closely with Lou over the past 2 years, or however long the pandemic's been going, both in the context of a long COVID clinic, but also in the wider hospital. He's asked me to address a very broad topic, mind and body, and I will reduce that immediately to the two major sort of topics of an outline of the psychological challenges of COVID-19 on the general population, and a review of the literature and clinical experience on persistent symptoms after COVID-19. There are many ways of approaching the psychological challenges of COVID-19, but this is the one I've chosen, and one I find reasonably useful. It's called world assumptions theory, which basically speaks to the notions that whether we are aware of it or not, we hold some basic beliefs within ourselves which we rely on in order to live in the world in a way that's tolerable and helps with our sort of day-to-day engagement. The three assumptions identified according to this theory is that the world is benevolent, the world is meaningful, and that oneself is worthy. Breaking these down, the world is seen to be benevolent both in terms of the general world, but also the people around us. In terms of meaningfulness, the world is makes sense. It's predictable, and to a certain degree, what happens in the world is a function of how we operate within the world. This leads to a kind of general notion that good things happen to good people, and an individual has ability to control his destiny. These are kind of ideas that I guess are fitting with a sort of positive culture, and not unreasonable expectations in the world without major events. The COVID has, in many ways, challenged these world assumptions, not only presenting us with the physical threat of illness or even the threat of our own mortality, but it's underscored a lack of certainty around what will happen, and delivered an imposition of restrictions which many of us have not been familiar with us, both in terms of not being able to do things because someone says we can't do them, usually the government, but also a decrease in social connectedness. I think a third element or a fourth element of the challenge of the COVID experience, and I'm sure people have many other lists as well, has been the information overload, not only the novelty of the information, but its changing nature, its complexity, and a degree of lack of consistency as to how it's presented. One way we can think about the impact of the COVID experience is a kind of decivilization, a challenge to our world assumptions, leaving us with less structure in which to conduct our day-to-day activities. This has been accompanied by an epistemological crisis. What is real? What is true? Can this be real or true? And in part, that can be related to the early responses to unbelievable or intolerable new information that occurs in grief, a kind of denial or a kind of shock, a preference for not believing something to be true as a way of not having to deal with it immediately. Not surprisingly, this kind of challenge has led to the emergence of new ideologies and the adoption of somewhat dichotomous positions, and we've seen this over many topics, in particular vaccination. But the positions are also kind of associated with the emergence of tribal narratives, which give a security. It doesn't matter what I think, as long as there are people around me who think the same thing, and that gives me a sense of security that I've lost through the exposure to the pandemic. There's also been a degree of personification, taking complex ideas and concepts and reducing them down to the actions or failure of actions of individuals. The villains no greater than Dictator Dan, and the heroes of Dr. Fauci, although he has interchangeably been a villain and a hero. And of course, this is all occurred in the context of an unfortunate parallel political process, which I'm sure hasn't helped our adaptation to the pandemic. So these challenges can be seen in terms of leading to, on a personal level, more individual use of more immature defences. And some of these defences can be used or can be seen as underpinning some of the attitudes towards health beliefs that have challenged us as health practitioners. Omnipotence, I can do it by myself with the power of my will. It just won't happen to me. Or, on the other hand, a fundamental emergence of fear and paranoia. I cannot tolerate anything to do with immunisation or treatment because I can't tolerate a further insult on my bodily integrity. A sort of an increased suspicion and untrustworthiness, even paranoia, such that one doesn't want to be experimented on. And the need to maintain control by making one's decision, even if it's the wrong decision, as opposed to suggestions that some other people strongly suggest you make a different decision. Devaluation is also a sort of central part of this response. most notably directed towards the Dr. Fauci in the United States, but at various other times, scientists and health professionals have been, and epidemiologists in particular, have been delivered a kind of devaluation which is usually reserved for used car salesmen, or if not, predictors of the weather. Looking at the COVID pandemic from a specifically mental health perspectives, it's interesting to note that early on in the perspective, there was a certain amount of catastrophization delivered to the Australian population by some of our leaders. Here's a couple of examples: sounding the alarm on a post-COVID suicide, and predictive models suggesting a doubling in suicide rates. When one actually looks at what available data there is, what actually happened is quite mixed. This, I think, is one useful study from the ANU Centre of Social Research and Method, which essentially used questionnaires on a cohort of people every 3 months, starting in February 2007, so clearly before the pandemic, and they were able to continue that data most recently till August 2021. Just reminding ourselves, though, that in this context, what we're talking about is how people fill out questionnaires, which is one degree, at least, maybe more, of separation away from the inner world of the individual, but represents some measure of change and the quality of their internal experience. It's not surprising to note that since the beginning of the pandemic, the quality of life satisfaction has decreased. In other words, if asked in various ways, is your life satisfying? People are more likely to respond in the negative. Conversely, questions about social cohesion have shown an increase, noting a sort of general pulling together, which is common during times of crisis, most commonly, of course, war. When we get back to the question of suicidality, a question that I've been asked a great deal, the suicide figures don't support the initial prognostications. If anything, there has been a decrease in completed suicides between 2019 and 2020. It is reasonable to note, however, that the impact of COVID has had differential impact on various subgroups. Groups that have been highlighted, not necessarily through the highest level of evidence, but through clinical experience and what is known about people's response in past crises, have identified youth, those with pre-existing mental health issues, the marginalised and disadvantaged, those in certain subcultures, those with poor employment security, and those in certain professions, in particular healthcare workers, as potentially more vulnerable to the impact of COVID-19. I think a further group, which is a hidden group but may well become a part of the tragedy that's described in the aftermath of COVID, is those people who had sick or dying relatives or friends who were unable to access them at very important times in their lives. Regards mental health usage, the evidence is patchy. There have been overall increases in demand on health lines such as Lifeline, Helpline and Beyond Blue, but the degree to which this corresponds with major psychiatric disorder of major distress is unclear. There's been no change in the amount of mental health related pharmacological prescriptions given, and that is a positive thing on many fronts. One is that one is not necessarily responding to increased distress if it is there using medication. What has increased, however, is the use of Medicare subsidised telehealth, which was an appropriate intervention and potentially protective against the emergence of psychological distress or even mental disorder. The second part of my talk relates more directly to our experience at Royal Melbourne Hospital in the long COVID clinic, and is a very brief précis of what is a very large and incomplete topic. I think at last viewing, if one puts the term long COVID into PubMed, there are more than 1,400 publications with long COVID in the title. We've known prior to COVID that there are post-viral syndromes, in particularly with SARS and MERS, one study suggesting up to 30% of people experienced some degree of physical symptoms at 12 months after SARS. Most commonly, they fall into the categories of fatigue, impaired concentration, memory impairment, sleep disorder, with some traumatic and affective symptoms as well. There are a number of cohort studies which have been conducted, and the methodologies varied, but this Norwegian cohort study, which has the benefit of piggybacking on a pre-existent study, I think is a good representation of the 12-month data, which is reasonably new. There's a lot of 6 months and 3 months data, and gives us a general picture about what people are reporting. These cases clearly would have been a combination of alpha and delta, but at 12 months of the 70,000 participants, about half reported altered smell, a quarter reduced lung function, with less than 10% reporting ongoing shortness of breath, pain, and the neurocognitive symptoms that were recognized more so in the aftermath of SARS. I think it's increasingly recognized that there are two major distinct groups who experience persistent symptoms. The first of these, and we certainly see these, are those who have had serious illness, often with prolonged ICU admissions and persistent evidence of tissue damage with scarring on their CT scans, as well as evidence of organ damage elsewhere. Then there's another group, and these aren't necessarily exclusive, but they do tend to shake out quite readily, are patients who often had mild symptoms, but who present with persistent fatigue, insomnia, brain fog, shortness of breath. And we'll talk a little bit more about that group, because that group is the group that's mainly been followed up at the RMH clinic. We have collected 12-month data on this group. The numbers are quite small, but it's representative of the larger cohort, which has probably been about 150 people through the clinic. As we can see, they were on average 32 years of age, predominantly female, and more than half were healthcare workers, most of whom were nurses. In our group at 12 months, and this is a group that's been selected down because of persistent symptoms, not necessarily just because they had COVID, there was a much higher proportion of symptoms than is reported in the general Norwegian study, which would be consistent with our selection bias. Interestingly, in this group, the neurocognitive symptoms, as well as the difficulty breathing, seem to predominate. Less commonly are the cardiac symptoms and persistent cough. Sort of features which were somewhat surprising, and we want to highlight this notion of sort of odd or unusual pain syndromes. The fact that there is a significant impact on occupation. Many of these people find it difficult to return to their previous role or return to work at all. And a number of them, perhaps 30%, have experienced some change in their symptoms following vaccination, although the sample size for this was very small. I think it was 3. A little bit about the sort of clinical experience of these patients. We took a very atheoretical approach to them, accepting the symptoms as they're presenting rather than predefining them as either psychological or physical. But what we did notice that for those with persistent symptoms after COVID, especially in the second group, there was quite a predominant focus on the physicality of the symptoms, a fear of not getting better, frustration about not being able to previously do things, as well as a degree of shame and stigma and fear that the symptoms would ultimately be described as mental or psychological or not real. Our approach was to not to prejudge what the symptoms were, to validate their existence, whatever their underlying nature, acknowledge the real uncertainty about what was going to happen, especially early on when we really didn't have any experience to share with them, increasingly over time, we've been able to share experience of other patients, most of whom have showed substantial recovery either around the 12-month mark or beyond that. Attend a principle of not over-investigating and not over-referring and not dichotomizing between mind and body, but treating and managing mental disorder when it's present. The key clinicians in helping this patient seem to be the exercise physiologists or the physiotherapists who help strike a balance between their desire to do more and the boom-bust cycle that inevitably occurs with fatigue. So in taking these two large topics together, I guess the conclusion is that there's something we all know, which is that COVID-19 has changed the world, but perhaps even changed the world, the way we think about the world, which may be defined in terms of world assumptions, but you may choose your own phrase. The effects of the infection are novel in as much as not many people got SARS or MERS, but in another way, we have seen similar viruses before. The nature of the persistent symptoms, I think we need to think of as being unclear, and certainly preemptively defining them as either biological or physical will kind of resurrect some of the great disputes that have occurred around other syndromes involving fatigue. And that this presents a challenge for us as medical practitioners to sit with the unknowing about what these symptoms are and not to get bound up too much in our own personal ideologies. Thanks for the opportunity to talk, and I'll hand it back to you, Lou, and look forward to the question and answer section. Thanks very much.
Alex, thanks for presenting on the psychological aspects of COVID-19. Our final presentation will be on physical aspects of COVID-19. It'll be presented by Jane Sinclair, a PhD student at the University of Queensland, where her honours project focused on the role of pre-existing chronic disease, especially diabetes, in the cardiac complications of SARS-CoV-2 and influenza virus infections. Jane's current work focuses on the long-term cardiovascular complications of COVID-19. Jane, welcome, and thank you for presenting to us today.
Thank you so much for the introduction. So hi everyone. I'm from Dr. Kirsty Short's Influenza and Coronavirus Lab at the School of Chemistry and Molecular Biosciences at UQ. And I've made a slight adjustment to the scope of my presentation today from what will appear on your program. So I'm mostly going to be focusing on the long-term cardiovascular complications that can arise from SARS-CoV-2 and influenza virus infections, although we will talk a little bit about Epstein-Barr virus as well. So I'm going to start today by giving a bit of an introduction to long COVID. It's usually defined as persistent, recurring, or de novo symptoms that can't be attributed to other diagnoses 4 weeks after the initial SARS-CoV-2 infection. It can manifest as a wide range of symptoms that may affect many different body systems, but the most reported indicators are fatigue and weakness, breathlessness, muscle ache, loss of smell, and difficulty concentrating, as well as a whole plethora of cardiovascular complications, which we'll be focusing on today. But long-term complications from respiratory virus infections aren't new. We see similar post-acute sequelae after influenza. So what is so scary about long COVID in comparison, and specifically, what are the implications of these infections for the heart? Let's compare the cardiovascular manifestations that we might see after infection with influenza or SARS-CoV-2. Though predominantly a respiratory pathogen, influenza A virus can not only worsen long-term medical complications like congestive heart failure, but also catalyze de novo cardiac injury, with hospital admissions for acute myocardial infarction increasing 6-fold in patients who have been diagnosed with influenza in the preceding week. Similarly, autopsy reports indicate myocardial injury to occur in 69% of fatal influenza cases. Infection has also been associated with increases in rates of endocarditis, pericarditis, tachycardia, ST changes, and atrial fibrillation, ischemic heart disease, and stroke. And most of these complications are detected within 6 to 14 days of symptom onset and are reversible in the vast majority of discharged patients, fully resolving within about 1 year of infection. There's also growing evidence of cardiovascular complications from long COVID. From collating different studies of patients initially hospitalized with severe COVID-19, we can see that at 2 months post-symptom onset, 21% still experience chest pain. Cardiac MRI shows that 11% of patients have abnormal left ventricular function, whilst 19% have myocardial infarction and 54% have ischemia or late gadolinium enhancement, LGE, which indicates myocardial fibrosis. Of patients with ischemic injury pattern, 66% in this particular study had no history of coronary disease. 3 to 4 months after infection, cardiac MRI shows LGE continued in approximately 30 to 31% of convalescent patients. And this is really concerning as LGE is an independent predictor of cardiac mortality in myocarditis. Around 6 months post-infection, 9% still continue to experience these heart palpitations, whilst a further 5% still experience chest pain. And now we have a new study showing symptoms 1 year after discharge, where 13% still experience chest tightness, and there are newly reported palpitations in 4.2%, and edema of the lower limbs, which is suggestive of congestive heart failure, in 1.4%. Amongst patients suffering from just mild COVID-19, the cardiovascular symptoms of long COVID are a lot less well defined, and in comparison, they appear to start resolving somewhere between the 4 and 6 month mark. One way in which cardiovascular complications of long COVID differ from those of an influenza virus infection is that symptoms are reported to come and go in waves. Here we have a quote from a patient suffering from long COVID. About 5 weeks in, I think it was for me, I was still desperately short of breath. A little bit better than right at the start, but it was still coming back in these massive waves. And I remembered ringing my GP from the floor on my lounge, lying on my front and kind of saying, I'm really short of breath, you know. Do you think I should try an inhaler? Do I need to go back to the A&E? So this is very scary, serious stuff, and it's happening to even young people who were previously healthy with no comorbidities. While long COVID is more common in people who experience severe acute infection, it really can affect anyone who's been infected with SARS-CoV-2. For example, in Australian ICU patients who recovered from severe COVID-19, approximately 70% sadly passed away or were still experiencing symptoms after 6 months. But even in patients who recovered from just a mild COVID-19, 35% still experienced symptoms 7 months later. And this is quite different from what we see with influenza, where we tend to see those cardiac complications emerging in patients who had really severe respiratory illness. Both long COVID and complications from influenza are more common in people of older age and people suffering from pre-existing chronic illnesses such as obesity, diabetes, or long-term lung conditions. Long COVID is also more common in females, which again, we don't see as much with influenza. Of course, we have to acknowledge the huge difference in scale of who's affected by these complications, simply as a function of how many people are affected by COVID-19 at the moment in comparison to influenza. And we're going to be making some sweeping assumptions here, but these are just very broad estimates to paint a picture. So acute myocarditis from influenza is clinically diagnosed in 0.4 to 13% of hospitalized adult patients with documented influenza. Now, it's likely that those hospitalized with influenza may be older and more prone to cardiac complications than the general population. But for our calculations, let's just assume the worst case scenario of 13%, so we don't underestimate the risk. In 2018, before the pandemic, there were about 50,000 lab-confirmed influenza cases in Australia. So if we make another assumption that for these cases to be lab-confirmed, they're all likely in hospital, we could estimate about 6,500 adults with heart complications after influenza in a year. Let's compare that with long COVID rates. So at the end of last year, a model was developed to reflect the potential acute and post-acute burden of COVID-19 using disability adjusted life years, or DALYs, under the Australian Border Reopening Plan. Scenario 3B describes a situation in which the community has achieved a vaccination coverage of 80%. We're operating off baseline public health and social distancing measures. We have partially effective test, trace, isolate, quarantine activities, and an outbreak is seeded with 300 to 1,000 cases, reaching about 40,000 cases per day around day 60, which is about where we're at as this is being recorded in late January. With this scenario in mind, the model predicts 17,464 years lived with disability, with long COVID accounting for at least 19% of the total base case dailies, more than 3,300 years in this scenario. That's long COVID cases in the hundreds of thousands, which we can see here in the solid purple line. When included in the analysis, permanent impairment could contribute to 51 to 55% of total dailies lost. So the number of cardiovascular complications we can expect to see come out of this is on just a completely different scale from what we can expect from influenza each year in Australia, to the point where this becomes a huge concern for our health system. So how is this happening? At the moment, we're not entirely certain for either virus, but it could be in many different ways, and it could be distinct between each virus. Currently, we don't know if early cardiomyocyte damage is linked primarily to virus presence or the resulting immune response in influenza infection. Influenza has been reported to replicate within human pluripotent stem cell-derived cardiomyocytes, and virus or antigens have been found directly in the heart in mice and humans in smaller case studies. However, a larger US study of patients with acute viral myocarditis identified the viral genome in cardiac samples from only 5 of 624 patients by PCR. And evidence of SARS-CoV-2 direct cardiac infection is also pretty contradictory. In vitro studies show infection and replication within human pluripotent stem cell-derived cardiomyocytes, but not smooth muscle cells. Autopsies of 39 COVID patients detected negative sense RNA indicative of active viral replication in the myocardium of only 5 patients with the highest viral loads. And in another autopsy study, SARS-CoV-2 positive cells in the myocardium were really rare despite viral RNA being detected in 30 of 41 hearts. Smaller studies of autopsy specimens from 5 and 8 COVID-19 patients respectively failed to detect SARS-CoV-2 within the heart entirely, even when patients displayed severe myofibrillar anomalies. So the contribution of direct viral infection to the development of these cardiac complications is still pretty unclear. For many long COVID and recovering influenza patients, complications are likely related to comorbidities or the non-specific effects of hospitalization. However, emerging literature has suggested a role of Epstein-Barr virus, the pathogen responsible for infectious mononucleosis or glandular fever. After infection, EBV becomes dormant inside our immune B cells and natural killer T cells, and people remain infected throughout their entire lives, usually without any symptoms. And this is really common. By adulthood, 95% of us are estimated to have this virus residing just latently in our cells. However, if the immune system becomes compromised, EBV can reactivate and cause re-emergence of symptoms such as fatigue, post-exertional malaise, cognitive impairment, and musculoskeletal pain. Sound familiar? If you're thinking that sounds a lot like long COVID, new research suggests that that's no coincidence. A recent US study found that 66.7% of long COVID subjects versus 10% of fully recovered patients were positive for EBV reactivation, with similar symptoms similar rates being reported in other studies. So could long COVID symptoms actually be attributable to this completely different virus being reawakened in the body? In our own study of 64 recovered COVID-19 patients in Queensland, patients who reported continued symptoms 60 days post-infection had significantly lower serum levels of the EBV protein that are in the latent life cycle stage than patients who reported no lasting symptoms. While this implied that our long COVID cohort might only have EBV protein from the lytic life cycle stage, testing for EBV positivity showed no significant difference between cohorts, with most patients in the study being positive. Because of this, we believe the symptoms of long COVID are not predominantly attributable to reawakened EBV. Rather, it seems more likely that the reemergence of this latent virus due to SARS-CoV-2 immune dysregulation is more of an effect rather than the cause of long COVID. And actually, a study has just been published in Cell showing that EBV reactivation during acute COVID-19 may be responsible for some few specific symptoms, but not others, and just at specific early time points. So what is the cause? Early in the pandemic, SARS-CoV-2 became notorious for its ability to cause cytokine storms even more dangerous than those caused by influenza, which attack the virus so ferociously that they accidentally damage the body's organs and healthy tissues in the process. by dysregulating type 1 interferons secreted by immune cells to fight the virus, a greater number and variety of cytokines is released into the system, resulting in greater immunological havoc than with other infections. Furthermore, this inflammation occurs all around the body, not just in the lungs, as seen with the respiratory inflammation caused by influenza. Emerging literature indicates that after the cytokine storms during acute infection, low-level chronic inflammation may drive long COVID in a subpopulation of recovered patients. In a study of 183 such convalescent individuals, approximately 10% had persistent symptoms up to 6 months post-infection, which were associated with elevated levels of serum inflammatory markers, monocyte chemoattractant protein 1, and platelet-derived growth factor. Similarly, long-term COVID-19 associated respiratory problems were linked to elevated plasma levels of inflammatory marker lipocalin-2. Importantly, serum levels of interleukin-6 at 4 weeks post-infection were positively correlated with chest CT score at week 8 post-symptom onset. And such immunological dysfunction has now been reported even 8 months out from infection, with long COVID patients showing highly activated innate immune cells, a lack of naive T and B cells, and elevated expression of type 1 and 3 interferons. And actually, we see this in our own studies as well. We tested serum donated from Australians who have recovered from COVID-19 2 to 4 months post-diagnosis to measure levels of 13 antivirus inflammatory cytokines. And at the time of donation, 19 of our 68 patients, or 27.9%, reported persistent symptoms, the most common being lethargy and fatigue in 6, or 31.6%, and respiratory and cardiovascular problems each in 4, or 21.1%. And we found that patients suffering from long COVID experienced significant elevations in serum interleukin-6, interleukin-8, and interferon beta. Could this inflammation be what's driving virus-induced complications of the cardiovascular system? Currently, the exact mechanisms remain pretty speculative. Studies other than our own have also reported elevated cytokine levels in the sera of convalescent COVID-19 patients, including elevated levels of proangiogenic MIP-1 beta, BDNF, and VEGF, which may again be either driving cardiovascular dysfunction or simply indicative of other causative factors. Alternatively, it is possible that therapies used during the acute phase of the illness, such as high-dose steroids, have their own long-term consequences for the heart, and this was seen in SARS-CoV-1. However, this wouldn't explain why we also get these complications in people who only had mild COVID-19, who wouldn't have received these treatments to begin with. After infection, patients may have increased cardiometabolic demand, also described in SARS-CoV-1 survivors, resulting in reduced cardiac reserve and dysregulation of the angiotensin-aldosterone system. Myocardial fibrosis, or scarring, resulting from either the acute inflammatory response or the viral infection itself, may also facilitate long-term disease, including reentrant arrhythmias. And on top of all of this, increased pro-inflammatory mediators in the blood may promote plaque rupture via local inflammation, and this can predispose to thrombosis and ischemia. If chronic inflammation is driving disease progression in some patients, anti-inflammatory drugs may cure or at least reduce these symptoms. And there are a few anti-inflammatory agents in clinical trials for this at the moment, with dupirfeniadone, or LIT-100, looking particularly hopeful after phase 1 trials, with phase 2 results expected around April, so keep an eye out for this. For now, though, it seems that the best treatment for long COVID is just prevention. A study released in December of 449 discharged hospital patients in Italy found that treatment with remdesivir during acute infection led to a 35.9% reduction in the long COVID rate at 6 months. And in this picture, we can see the post-acute functional status, a score, of patients with and without remdesivir, with the lower scores in black signifying fewer and milder symptoms. While this is a relatively small study, it does give some hope that other antiviral therapies like Paxlovid and molnupiravir may have a role in reducing the risk of developing long COVID. Can vaccines prevent long COVID? Theoretically, it's very possible. So if long COVID is inflammation-driven, vaccination allows the body to launch a more targeted immune response earlier on, and this reduces the chance that non-specific immune reactions might target our healthy tissues. And actually, studies have shown influenza vaccination shortly after myocardial infarction or in high-risk coronary heart disease to reduce the risk of future heart attack or stent thrombosis by 28% and cardiovascular mortality by 41 to 50% at 12 months, possibly due to such modulation of inflammation. A study of the US Veterans Health Administration electronic databases compared the risk of organ system involvement in 16,000 people with breakthrough COVID-19 after vaccination with 2 doses, with about 48,500 unvaccinated COVID-19 convalescents at 6 months. The vaccinated group showed lower risk of long-term fatigue, coagulation, and metabolic, pulmonary, and cardiovascular sequelae compared to the unvaccinated group. On the other hand, data obtained from the US TriNet-X electronic health records show 10,000 vaccinated COVID-19 patients experienced no lower long COVID risk than matched unvaccinated controls in the 6 months after infection. However, the difference in these results might be because the second study looks at health records rather than self-reporting of symptoms through a survey. So they might only be capturing just the most severe presentation of symptoms here. The use of vaccines as treatment for long COVID is also uncertain, with many studies limited by small cohort sizes and self-reporting methods. In the largest study, the medical history of 240,000 COVID patients were analysed to find that unvaccinated patients who received their first dose within 4 weeks of infection were 4 to 6 times less likely to report multiple long COVID symptoms, and those who received it 4 to 8 weeks after were 3 times less likely, compared to those who remained unvaccinated. However, other studies found that while 40 to 58% of patients reported improvement in their symptoms, another 14 to 18% reported deterioration. And one such study reported larger improvements in those receiving mRNA vaccines than adenoviral vector vaccines. However, this remains to be validated. What we can say for certain is that there is enough preliminary evidence of potential benefits of vaccination as treatment, but especially as prevention of long COVID, to warrant large-scale controlled studies. And whether or not vaccines do prove to prevent long COVID or not, they do reduce long COVID incidence indirectly just by reducing your risk of becoming infected. And this should really be something we're drawing more attention to in the Australian discussion of the risks and benefits of vaccination and boosting, as it might influence vaccine acceptance on an individual level. I've included a list of references here in case anyone wants to read up more on some of the studies that we've gone over today. And I'd just like to say a huge thank you to my supervisor, Dr. Kirsty Short, our collaborators, Associate Professors Kim Jacobson and Stephanie Grass at Monash Biomedicine Discovery Institute, and Associate Professor Corey Smith at the QIMR Berghofer Medical Research Institute, for all of their contributions to the experimental results that I've discussed today. Thank you as well to the Immunisation Coalition for giving me the opportunity to talk today, and thank you all for listening, and I'm looking forward to the questions. Thanks.
3 fabulous presentations, thank you, with lots to talk about. Stanley, you first. Your amazing description of the large variety of coronaviruses illustrates that it's a wild and dangerous world that we live in. So someone's asked, will social distancing actually, reduce the behaviour of some of these viruses? Particularly, for example, common cold viruses, influenza, etc.
I think we learned the answer to that question without even doing the study, because just talking to people who I know and people I hear about, the number of colds last year when everybody was wearing masks more reliably and were socially distancing more reliably, the number of influenza infections, the number of common cold infections was greatly decreased. Of course, we don't know what this means in the long term, because that yearly boosting of immunity may make a difference. So it's really a work in progress, just like this whole pandemic has been. We're learning as we go along.
But there are different ways of boosting our immunity, I guess. Are you suggesting that exposure to coronaviruses is a good way of doing it, or are there safer ways of doing it?
Well, I think that For common cold coronavirus is probably a question, something one could think about. I personally wouldn't do it, but one could do it. But certainly for the more severe ones, I wouldn't want to have the risks of the long COVID that Jane talked about at the end and that Alex talked about. So that I think that that's not a safe way to do things. I think I was referring more to that we don't know if people are exposed more to flu and exposed more to cold just in their normal everyday life, how they will handle those infections, if it will be identical to if they hadn't skipped a year of being exposed to those pathogens.
And is it understood why MERS and SARS only become contagious once there's very significant lung infection rather than upper airway infection?
Yeah, I think this is the key question for SARS-CoV-2. So why is this an upper airway infection? I'll turn the question around. When SARS was a lower respiratory tract infection, the receptor for the virus is in both places. And so we really don't know why the virus, why SARS-CoV-2 likes to infect both the upper respiratory tract and the lower respiratory tract. SARS infected only the lower one, but then there's this third virus, NL63, which also uses ACE2 and only infects the upper airway. There's a little bit of lower tract infection, but it's mostly the upper airway. So whether there's a cofactor for each virus, there's something that's really important for understanding how these viruses work. And we want to know because more and more data are coming out, often from people in Australia, describing the large number of different coronaviruses that are out there in bat caves, and some have the potential to use the human ACE2 receptor. So I think this is really important question about why SARS-CoV-2 could infect the upper airway and SARS-CoV could not.
Could it be a matter of dose that that once the lung's infected, there are much higher exhaled doses of virus?
Well, that would explain why only some people with SARS were contagious, but I don't think it explains SARS-CoV-2 because people are contagious 2 days before they develop any symptoms. So, the highest virus loads are in the upper airway. That's pretty certain. So it's only a minority of people who get a lung infection. There's so many people infected. That's why we've been so overwhelmed with the lung infection, but it's actually only a minority of people who really have been infected with the virus.
With the discussion will centre around long COVID for a while. The concept of recrudescence, do you think that it might be an explanation for long COVID?
Do you want me to answer that, or the two?
You to have first go, and then
okay.
The others.
Oh, yeah. So I don't think there's much evidence for virus persistence. That's not true for people who are immunocompromised. For those people, virus is not clear, just like the mice that I described in my presentation. So virus could recrudesce, but it doesn't really even recrudesce. It really persists rather than recrudesces. I think it's more being reinfected because there's so much virus in the community. So I worry less about even in the studies that show little bits of virus in long COVID patients. I think it's really low, and I don't think that's the explanation. Of course, there could be low levels of virus RNA in some tissue that is triggering some sort of an immune response. Really hard to know because people who have long COVID, we can't study them obviously because they generally survive, which is great, and we don't have access to tissues that might be affected.
Stanley, thank you. Alex, there's a question I think is close to your heart, and is could a doctor confidently write a sick certificate or a disability pension in someone with long COVID? If so, what test would prove the diagnosis, or would it be a mental illness? And I know you've thought about this a lot.
Okay, well, look, there's a number of questions in that question. Perhaps I'll address it from the point of view of context. I mean, it's not a medical question, really, whether someone's on a disability. It's almost a legal, pragmatic question of fulfilling criteria. And the criteria for disability is inability to function to the degree that there's some suggestion of persistence. So another way to address this is, do I think that some people are going to have persistent symptoms to the degree that they're unable to function? I think inevitably the answer to that is yes. I think it's kind of cruel and inhuman to say that it's not because we don't want it to be, or it shouldn't be, or we've never seen it before. The answer is going to be yes. the degree to which that is underscored by a kind of understandable biological mechanism or immunological mechanism or psychological mechanism is a stuff to keep, you know, fertile minds interested for the next generation. But if but that's really shouldn't prevent the person themselves being responded to by the community in the same way that anyone else who can't function should be responded to. As you know, we've been very keen to avoid, you know, designation of biological and psychological, and certainly in our experience, this psychological symptoms and the biological underpinnings and what else is going on seem to have correlations that, frankly, we can't fully understand. It's like we don't quite have the models to link immunology, affect, thinking, even social reinforcements, you know, the effect of stopping and not being able to start again. I just don't think we have sophisticated enough models, and we shouldn't make the patient responsible for the fact that we can't understand things. So I think as much as possible, we have to avoid dealing with our own unknowing by sort of making it the patient's problem and just call it our own unknowing.
Alex, there's a second question about and sorry, it turns out to be a typo. So can I ask you, is there a sort of a vaccine equivalent for our psychology to protect our worldview, you know, so that it doesn't get battered by these existential crises?
So this is,
or do we just have to go with the flow?
This would be a completely evidence immune answer, in as much as I think life experience immunizes us against change. So a life well lived. I mean, there is certainly a kind of notion that past adversity, if it's not traumatic, helps people dealing with future adversity. I think that, you know, we have been living in a somewhat Camelot period since the Cold War, by virtue of the fact that, you know, what did Einstein said that the Fourth World War would be fought with bows and arrows. So that sort of reasonable protection from existential threat for a few generations perhaps has left people, apart from very older members of our community, you know, more prone to thinking that nothing possibly can go wrong. I'm not suggesting we use war as to immunize us against change, but perhaps this has just introduced us to a kind of element of a life that most people had to live, which is significant existential threat.
So there's a question asking whether we're evolving in a positive or a negative way with regard to recurring existential threats. Are we better evolved now compared to people in the First World War, for example?
I don't think there's better or worse. I think we do it differently because I think the forces of media are so predominant in how we perceive information that, you know, you had to go down and pay your 2p for the Sunday paper in World War I. Now we get this sort of tidal wave of information. So I think it's impossible to compare. I think certainly if one marker of maturity or civilization is the ability to remain cohesive across different points of view or in the state of threat and unknowing, then, you know, many countries, and, you know, I think most countries have actually demonstrated great resilience. I mean, we've focused on the kind of negative aspects, but they're just clickbait, really. Mostly governments have been impressive, certainly in Australia, and I think in the United States, and mostly in adapting quickly to what was an unexpected challenge.
Alex, thank you. Jane, congratulations on a wonderful presentation. Your data about persisting inflammation in people with long COVID, and I'm guessing that some of them had relatively mild initial disease, What do you think's the site of the inflammation? Where is it actually coming from? Which organ?
Yeah, sure. So that's something that's quite hard to tell from the sort of test that we're doing. So this is just serum. And I think I mentioned in the presentation that based on the sort of cytokines that we saw elevated, for example, interleukin-6 can be a marker of this continued inflammation, but on the other hand, the heart itself can actually secrete interleukin-6 in the short term to protect itself against viruses and things like that. However, I think that if it was secreted by the heart in this circumstance, we would need to sort of get serum from a very specific time point to see that. So we can't answer that with the sort of test that we've done for that cohort, but we can certainly make some predictions as well. And the other thing that I didn't really go into too much in my presentation was that a lot of studies are now finding evidence of continued microclots in people that have had COVID-19, and a lot of the time it stays in these patients that can keep experiencing symptoms months and months later. And these microclots, they're quite resistant to fibrinolysis. So they sort of, they clot together, and in the serum in the middle of the clot, there will be all of these pro-inflammatory mediators that can't be detected in regular blood tests. So even in our cohort, which that's the sort of test that we did, just take serum and run a Legenflex, you can see that the serum levels of these inflammatory markers, even though they're elevated in our long COVID patients, they're still quite low. So this is something that, yeah, regular tests can't detect, and we need to find better ways to find these things because, yes, as Professor Alexander Holmes has said, this discrimination between mind and body tends to be, it's our own failure. We have, just because we can't detect these things in our tests yet doesn't mean that there isn't a physiological basis for these continued symptoms.
So, Jane, there's a question about emerging biomarkers. Are there any that you've got an eye on? Can you predict some that might show up?
Certainly. So there are studies coming out now that show certain immunoglobulin patterns that are predictive of people that will go on to experience post-acute sequelae from COVID-19. There are also something that we're working on with some collaborators is to develop a much more specific test than the one for the results that I showed today. So this is a little cytokine chip, and you can design it so that it specifically detects a couple of cytokines that we know seem to be associated with long COVID. And we think that what we can detect from this is we can detect cytokine levels to a much more sensitive degree. And what we believe we'll see is that with how the symptoms of long COVID do come and go in waves, we believe that we'll be able to keep an eye on these patients that we think are more likely to go on to experience long COVID. And we can test serum at different levels and probably detect increased inflammation even before their symptoms come back. So for that, we'll be able to predict and sort of treat almost prophylactically these symptoms that might recur. Yeah, does that sort of answer that question? I think there are lots of other things as well as patient factors as well. Like if someone's got all of these pre-existing chronic illnesses, they're maybe female, they're a bit older, then those are all patient factors as well that you'd look to think they're probably some of the more likely people to go on to experience this.
Jane, thank you. Stanley, there's a question about the likelihood of using a live attenuated SARS COVID-2 vaccine. Do you think it'd ever eventuate, or is the risk too great?
Yeah, I fear that the perceived risk will be too great. Whether it'll actually be too great is another question. People are developing replicon type vaccines, so what viruses that can replicate well but can't propagate from cell to cell. So those might have some promise. That might have some of the ability to induce good immune responses, such as the live attenuated vaccine. But our experience with live attenuated vaccines with other coronaviruses has not been stellar. So even though some of my friends are developing them, I just don't know that they'll ever get regulatory approval. They certainly would be great if they work because they give you the best response. But we can't have people getting reverted virus. We can't have new versions of the virus coming out from the vaccine strains.
Thank you. The final question for each panel member is: you have a crystal ball. It's and you're looking 50 years in advance. Will there be an explanation for long COVID? So, Stanley, starting with you, is this another example of a transient post-viral disease that never occurs again, or?
Well, I think that we will have an explanation, and I think it won't be transient because I think that people who have COVID-19 will be affected for much longer than we like. And what we learned from, this is the same thing that we saw in 1918 with the encephalitica lethargica, then this will come back in some other form. So we need to know as much as we can about it. But as has been said, we really don't really know what's going on yet.
And will it be something we can see under the microscope, or will it be in the mind?
Oh, as Dr. Holmes said, I think it's going to be definitely a combination of the two. I don't think we can separate them.
So, Dr. Holmes, what do you think?
50 years is a very long time in medicine. I would think that in 50 years' time, we'd have a pretty sophisticated understanding. But part of a sophisticated understanding is a degree of metaphysics whereby we can attribute a psychological process around physical mechanisms and say, that's close enough.
And Jane, you'll be around to tell us, but what do you think?
I think I certainly hope that in 50 years' time we have a much more comprehensive explanation than we have now. I don't think it will be one explanation. I think that there are lots of different theories going around at the moment, and I don't think it's going to be any one of them. I think for different patients, it will be different mechanisms behind it. And I think that it will be, this mixture of mind and body.
A very wise conclusion to a fantastic session. Thank you to the three speakers and panelists. It's time for us to finish.